endocrinologist in Boston at Brigham and Women's Hospital, and an assistant professor of medicine at Harvard Medical School. And I was invited to give this discussion regarding the clinical utility of renin measurement in hypertension. I have a clinical and a research interest in renin and how it might be used to help differentiate various types of cardiometabolic conditions. As I put up the disclosure slide, I'll just make one disclaimer. I'm in no ways an expert in renin assays, so I'm going to try to focus most of my talk on clinical applications of renin. So we'll get started with a case because I think it's a little bit easier to introduce the topic. There's a 54-year-old male who presents with a history of resistant hypertension. This was diagnosed at age 35 following an emergency room visit after a motor vehicle accident. Both of his parents were reported to have hypertension in their 40s, and he also has an older sibling, age 41, with a history of hypertension. And I have a graph down below that shows his body mass index, which has increased steadily from age 27 to his present age, from 24 to 36. And when asking about his medication history, he reports being placed on hydrochlorothiazide when he was first diagnosed with hypertension, and then this was added with metoprolol and then enalapril, and this was exchanged for amlodipine after he developed a cough to enalapril. His blood pressure on visitation was 158/94 with a slightly elevated heart rate. Of note, he had an echocardiogram in 2009 which revealed moderate concentric ventricular hypertrophy as evidence of the chronicity of his disease. Other significant history consists of him quitting tobacco use 15 years prior, history of past heavy alcohol abuse, but none in the last 2 months. No present drug use, although he had admitted to dabbling in the past. He reported no control of his dietary salt intake, and he said he was mostly a sedentary. Instead of playing basketball games, he enjoyed watching his kids play basketball games. He was a machinist by trade and had sporadic work lately. His past medical history, aside from hypertension, consisted of a mixed dyslipidemia of about 8 years, for which he had a cardiac stent for what was reported as dizziness, and interestingly, he says despite having the stent, he still has dizziness. He had a rotator cuff repair and arthroscopic knee surgery for a torn meniscus. On exam, he's obese. He has a notable 20-inch neck circumference, and he has evidence of end organ damage in his eyes with retinopathy. No audible bruits were encountered. His laboratory tests revealed a marginally low potassium of 3.5, a normal serum creatinine, a slightly elevated microalbumin, and a plasma renin activity, which you'll note was somewhat suppressed at 0.6 nanograms Ang1 per cc per hour, and an elevated aldosterone level of 60 nanograms per deciliter. Of note, a 24-hour urine collection was obtained, which revealed an elevated sodium of 216 millimoles and an inappropriately elevated aldosterone, which we will talk about later. So the diagnosis here would be consistent with primary hyperaldosteronism. He had evidence of a suppressed renin activity, an elevated aldosterone, and an inappropriately elevated aldosterone despite a high sodium intake. He was treated medically with 100 milligrams of spironolactone daily. This was subsequently changed to eplerenone due to development of gynecomastia, and his blood pressure was well controlled, as was his serum potassium levels. So I think this typifies how renin measurements are used more and more lately, and it, for the most part, has to do with the assessment of resistant hypertension and the increased recognition of primary hyperaldosteronism in that population. So I'm going to quickly review some of the background of renin itself. Renin as a molecule was discovered in 1898 by Tigerstedt and Brigham in Stockholm. It's actually a pre-pro molecule 406 amino acids, with the mature molecule, renin, being 340 amino acids. And we see here I've partitioned the slide into two segments. The upper segment is trying to depict the renal component of renin, which is the juxtaglomerular apparatus, or JG cells. And you can see that prorenin has a pro-segment, which is that darker blue blob within the renin molecule. This is proteolytically cleaved to active renin. Renin is actually an enzyme with the responsibility of converting angiotensinogen to angiotensin 1, which in turn is converted to angiotensin 2, which affects blood pressure. On the lower half of the slide, you'll see extrarenal production of prorenin, which has been described in various tissues, including the adrenal gland, retina, and ovary. I point out that prorenin itself can have two conformations, and this is important when utilizing and interpreting various renin measuring assays. The closed conformation is what prorenin is mostly in. It's 98% of the time in that position, and that is typically undetected by renin measuring assays. However, the open conformation of prorenin consists of about 2%, and it is indistinguishable from assay measurement. So assays that measure the renin active enzymatic site will detect and report both renin concentrations as well as prorenin concentrations in the open conformation. As far as the effects of renin on the cardiovascular system, there are three major stimuli for secretion of renin. They include hypotension, probably most profoundly, followed by sympathetic stimulation, and then decreased sodium delivery. All these lead to secretion of renin, which I mentioned converts angiotensinogen produced by the liver into angiotensin 1 through an enzymatic process. Angiotensin 1 is then converted to angiotensin 2 by converting enzyme activity, and then angiotensin 2 produces effects that ultimately raise blood pressure through at least three mechanisms: through stimulation of aldosterone production and sodium retention volume expansion, through direct vasoconstriction to increase blood pressure, and by antidiuretic hormone to raise blood pressure. And you can see this knowledge of these enzymatic processes and various steps throughout the renin-angiotensin-aldosterone system have led to the development of specific antagonists at each step. Beta blockers interfere with renin secretion by blocking the sympathetic stimulation drive. Renin inhibitors block renin activity such that it cannot convert angiotensinogen to angiotensin 1. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, and angiotensin 2 antagonists, type 1 antagonists, block the effects, the terminal effects of angiotensin 2. Finally, aldosterone its actions can be blocked by mineralocorticoid receptor activity, antagonism. Interestingly, to compare different renin-angiotensin-aldosterone system blockades, renin in particular leads to an elevation in renin concentration, renin blockade leads to an elevation in renin concentration but lowers plasma renin activity, whereas the other antagonists will raise renin concentrations but also raise renin activity. The ultimate negative feedback is via angiotensin 2 in a tonic process. So renin measurement is essentially measured by two methods. The first would be described as enzymatic activity of the renin enzyme, and this is most often described as plasma renin activity. Typically, this is a radioimmunoassay that measures the amount of angiotensin 1 generated over a period of time. It's a somewhat cumbersome and expensive assay and is very technician heavy, and it's incredibly sensitive to poor sample handling. Temperatures will affect the folding and unfolding of the prorenin molecule, which can affect the detection of the enzymatic, the active site. So there must be particular proper handling of samples to maintain a reproducible result. Reproducibility is good, but it has poor sensitivity at very low values, and that'll come into play in a minute on the next few slides. Typically, the normal values are 1 to 4 nanogram of angiotensin 1 converted per cc per hour, and this is typically done in a seated, upright position in the morning for best reproducibility interpretation. A second way of measuring renin is by direct measurement of renin concentration. This is typically done by an automated immunometric assay. It's comparatively easy, although it does have some limitations in that renin concentration itself measures the concentration of an enzyme, but does not reflect its enzymatic activity. And it's substrate dependent, meaning that estrogens and other molecules that alter the substrate concentration, in this case angiotensinogen, can affect the total amount of renin measured, yet not reflect the amount of renin activity produced. Normal values are typically 8 times that measured of plasma renin activity, measuring 8 to 35 milliunits per liter. And that's a pretty good rule of thumb of trying to convert between plasma renin activity measurement and renin concentration. It's about a 1 to 8 ratio. It's important to remember the various factors, environmental and otherwise, that affect renin measurement. In particular, on the left hand is upright body position. The renin-angiotensin system is exquisitely sensitive to the effects of gravity. So maintaining an upright posture, or at least maintaining a rigor in standard operating procedures for measuring renin, will enhance reproducibility and the ability to interpret properly. The aging process generally leads to a decrease in measured renin, both renin activity and renin concentration. African American race also tends to have lower renin concentrations, and there is diurnal variation of renin with higher concentrations observed in the morning hours. Pregnancy is known to affect renin by raising levels, and the luteal phase of the menstrual cycle has invariably been reported to raise renin by some investigators. The second most important factor to remember are the medications that are often in place while somebody is measuring renin. Diuretics, as one might imagine, lead to volume depletion and a reactive elevation in renin activity as that is sensed. As I previously mentioned, beta antagonists will suppress the sympathetic nervous system drive on renin secretion by the kidney. ACE inhibitors and ARBs again affect the negative feedback on plasma renin activity. And renin inhibitors in particular can be difficult to interpret depending on the assays, as they can have variable effects on both renin activity and renin concentration. Medications that tend to have less of an effect on measurement of renin or the activity of renin activity include hydralazine and alpha antagonists. And sometimes these are chosen when trying to interpret the effects of renin in a case of hypertension by replacing other medications that might alter renin activity. As I mentioned, dietary salt intake is probably one of the most important factors, environmental factors, that affect our ability to accurately measure renin and its impact on blood pressure. As sodium intake, dietary sodium intake increases, renin activity should be suppressed. Unfortunately, the problem is that in the U.S., dietary salt intake is fairly high, ranging between 7 to 9 grams of salt per day, or about 150 to 170 millimoles of sodium per day. In other countries such as Japan, this is even factor, and it is even higher. So you can see how this would be an increasingly important factor and try to interpret the sensitivity of a renin measurement. as the slope drops off. And again, that'll come into play as we discuss some of the clinical applications for measuring renin. So how exactly is renin used clinically? I would say, in my opinion, it's probably in the measurement or the assessment of causes for resistant hypertension. And then beyond that, it's probably less used except by specialists, and that would be to measure assessments of adrenal incidentalloma, measurements of potassium disturbances, assessment of renal reserve and how much renin can be produced by the functioning kidney or failing kidney. And then very rarely it's used to measure situations such as adrenal insufficiency or Cushing's. As I mentioned at the onset, renin activity measurement is an incredibly active area of research since renin reflects the volume state of the circulating vascular system. So it can be invaluable in, as a research tool to assess volume status, blood pressure function, and cardiovascular function in general. As I mentioned at the onset, probably the number one cause for the uptick in renin assay measurement is the recognition of a higher prevalence than previously recognized of primary hyperaldosteronism. As you can see from this graph, around the time that hyperaldosteronism was described by Kahn in the mid-50s, it was thought that the prevalence of this condition was fairly low. But you can see over time it's been recognized either through a combination of increased screening or enhanced assay detection that in the general hypertensive population we see a reported prevalence of primary hyperaldosteronism of between 5 and 8%. And when looking at referral hypertension centers, that prevalence rises to 25%. Resistant hypertension is probably, as I mentioned, the number one reason why renin would be measured. And according to the Joint National Committee 7 definition, resistant hypertension is described as an above goal blood pressure of greater than 140/90. This is generally despite 3 optimal doses of antihypertensive agents. Key here is implied adherence. So medications must be consumed, not just prescribed. It does not necessarily mean maximum doses of these medications, but it must include a diuretic. Or the presence of 3 antihypertensive agents, controlled or not. So you can see how this definition can include quite a large group of the general hypertensive population. The prevalence has been difficult to know. It's been reported by N. Haynes and Framingham that about 50% of hypertensives are controlled. In high-risk populations, such as those with diabetes and chronic kidney disease, only about a quarter to a third are able to reach goal blood pressures. However, that doesn't necessarily mean they're resistant because compliance would have to be assessed first. Our best guesses probably come from ALHET, which reported a 34% uncontrolled blood pressure rate on 2 antihypertensive medications, or NHANES, which showed a 15% rate. One could estimate that since BMI, diabetes, and age are all risk factors for the development or conversion to resistant hypertension, that the prevalence of this state will increase over time. It's important to investigate secondary causes for resistant hypertension. Obstructive sleep apnea has a very high prevalence in causes of secondary resistant hypertension, but I've outlined here 3 particular conditions which have to do with renin, and this would be renal disease, primary aldosteronism, and renal assessment of renal artery stenosis. Other causes which are much rarer include pheochromocytoma, Cushing's through a multifactorial series of events, a hyperparathyroidism, and aortic coarctation. The biochemical evaluation of primary hyperaldosteronism, of resistant hypertension usually begins with a basic chemistry panel and a urinalysis. We typically at our center also measure morning renin and aldosterone. If it's highly suspicious, then we'll obtain a 24-hour urine creatinine, sodium, potassium, plus or minus the addition of aldosterone, metanephrines, and free cortisol. And the reason why we tend to do that at onset is, one, we're a referral center, and two, there appears to be a higher prevalence of high sodium excretion in the population. I would say less so these days is the investigation for renal artery stenosis. Only with very high suspicion, such as younger women, acute onset, or in older individuals with known atherosclerosis, would there be an investigation for renal artery stenosis. The interpretation of the aldosterone renin measurements is important, and I'll divide it into three states. The first would be we'll describe as low renin states, and these would be, as you might imagine, conditions that would suppress renin activity either due to hyperactivity of another volume-dependent hormone or through volume overload state in general. As I mentioned, probably the most prevalent would be primary hyperaldosteronism, in which the measured aldosterone level is very high, but the renin activity is low and suppressed. Similar to this would be ingestion of licorice. This would has high mineralocorticoid activity. It would suppress aldosterone, but it would also lead to volume expansion and suppression of renin secretion. Much rarer would be doke-secreting tumors, 11-beta hydroxylase deficiencies, and ectopic ACTH. The next category would be a value returned of renin in the normal range. Sometimes this can be observed in conditions of the Cushing syndrome, in which both normal aldosterone and normal activity are observed. This would be followed up with investigation of cortisol measurement if clinical suspicion was high. Finally, the last category would be a return value of renin in the high range. Again, this would be probably most consistent with renovascular disease, in which there is impaired blood flow to the kidney and a perceived hypotensive event, which leads to stimulation of renin. So both renin activity would be high, and consequently aldosterone activity would be high, as driven by renin. Much rarer would be reninoma, or a tumor which secretes renin. But importantly, malignant hypertension. So in the evaluation of a patient in the emergency room who presents with hypertensive urgency or emergency, it is not uncommon to measure very high levels of renin, aldosterone, and metanephrine activity. As one can imagine, if there's a relative volume deplete state, circulating volume deplete state, such as congestive heart failure, nephrotic syndrome, or cirrhosis, one would expect to see elevated renin and aldosterone activity. In measuring and screening for primary hyperaldosteronism, probably the #1 secondary cause for resistant hypertension, the aldosterone-renin ratio is most often used. It is, one could imagine, heavily dependent on renin, which resides as a denominator. Unfortunately, there have been no established cutoff values for plasma for this aldo-renin ratio. For plasma renin activity, it's generally been between 25 and 50. For use of renin concentration in the aldo-renin ratio, the assay sensitivity, as reported by several societies, including the American Heart Association, requires the sensitivity to less than 1.2 nanograms per liter, or less than 2 millionaire units per liter. For use of plasma renin activity in the aldo-renin ratio, the assay sensitivity should be able to measure less than 0.3 nanograms per milliliter per hour. And these, again, as I mentioned, become important because of the suppressed renin values we naturally see in a high sodium diet. So where there's an increased dependency and weight to renin residing in the denominator of this aldo-renin ratio, the ability to measure renin accurately at very, very low levels is important. For plasma renin activity, this usually becomes a stumbling block, and often assays will depend on a prolonged incubation period of up to 18 hours in order to accurately report renin activity when concentrations are less than 0.5 nanograms per milliliter per hour. Optimizing the sensitivity includes morning sampling, a standard operating procedure for being seated from 5 to 10 minutes, typically an unrestricted salt diet, and at least 2 hours out of bed in the morning. Other disease states beyond primary hyperaldosteronism that might alter renin include primary adrenal insufficiency. The phenotype is often that of hypotension and hyperkalemia, and as one could imagine, in a volume deplete state, the renin activity would be very, very high. Secondary adrenal insufficiency, curiously, has hypotension and normal kalemia. We typically don't see a markedly elevated renin in this state, as the hypotension is not as profound and there is not hyperkalemia. Chronic renal insufficiency is a state of hypertension and hyperkalemia. Depending on the degree of renal insufficiency, this may impair renin secretion or renin production, so renin levels may be low in this situation. As mentioned, renin-secreting tumors lead to profound hypertension with hypokalemia, and renin levels would be markedly elevated. Any syndrome or genetic defect of steroid biosynthesis can lead to either symptoms of hypo or hypertension and potassium disturbances. And as one can imagine, the effect on renin secretion is variable depending on the degree of hyper or hypotension. So in summary, renin is the rate-limiting step that we see in the production of angiotensin II formation. It is a key regulator of blood pressure and volume homeostasis. Renin measurement is increasingly important in the evaluation of hypertension. Available assays reflect either renin activity or active renin concentrations. And the interpretation of renin values is dependent on the collection conditions and a solid understanding of the environmental influences that affect renin. So at this point, I'll entertain any questions that you might have, and certainly feel free to contact me at my email listed on the screen. Or if you need a copy of the slide set, I'd be happy to provide that as a PDF file. So I'm going to look over at our questions screen to see if there's any at this time. And if there's any participants, they can ask questions at this time. So I have one question here that asks, can a single renin measurement be used to determine treatment for a newly diagnosed hypertensive patient? That would depend on the suspicion for a resistant hypertensive state. So at the time of diagnosis of hypertension, if the blood pressure is markedly elevated or there are signs and symptoms that are worrisome for a secondary cause, such as chest pain, early age, severe onset, or a striking family history, then renin could be measured at the onset. I would say that would be a rare condition, in that renin is most often measured in the evaluation of resistant hypertension. Resistant hypertension typically develops over time or is described over time and not at initial presentation. I would say most hypertensive patients who are resistant hypertension, it is discovered after a series of trial and error medication maneuvers. So there might be an initial medication or two attempted to lower blood pressure without an optimized effect, and then a third medication is added. So at least 2 or 3 office visits would occur with assessment of blood pressure response to standard medication. And then, after failure of those medications to optimally control blood pressure despite compliance or evidence of compliance, then a biochemical evaluation for resistant hypertension, including measurement of renin, would typically occur. So at this point, given the low prevalence of primary hyperaldosteronism in the general hypertensive population, and in particular in stage 1 hypertension, we are not screening with renin for that condition. One can imagine that primary hyperaldosteronism in some regard must start at some point, and even individuals who enter into a diagnosis of hypertensive with a marginally elevated blood pressure, even if inappropriate aldosterone secretion is the mechanism behind that, it may not be realized until several months later as the aldosteronism grows or worsens. One would hope that as our abilities to better phenotype and characterize the hypertensive population, either through genetics or other mechanisms, that we'd be able to detect these individuals earlier. And one can envision a day in which we would be able to determine who exactly has a particular tendency to develop resistant hypertension, or even primary hyperaldosteronism, with some sort of screening tool, either renin measurement, aldosterone measurement, or a combination with genetics to better treat these individuals. So the next question that we have is, are there any suggestions on educating physicians on switching from a PRA result to a direct renin result? I'm assuming this is referring to the conversion of the actual number. So as I mentioned earlier, typically plasma renin activity values are reported between 1 and 4, whereas plasma renin concentrations are between about 8 and 35. So a general rule of thumb I use is to multiply the PRA by 8 or divide the PRC by 8 to interpret the values or interchange them. I'm not sure if that's answering the question. And I'll wait to see if there are additional questions at this time. So a great question that was brought up is, what tests are used to confirm a diagnosis of primary hyperaldosteronism? Usually there are 3 tests. The ones that we use in our center is an oral sodium loading protocol. So once the screening aldosterone-renin ratio is confirmed, we typically do a salt loading. This consists of about an additional 100 to 150 millimoles of salt intake orally per day. Now you have to be careful with that depending on the degree of hypertension. So if somebody has profound hypertension, we probably wouldn't do that, and we'd have them come into our inpatient center for an evaluation. In addition to salt loading, it's important to realize that can exacerbate potassium losses. So typically we'll prescribe oral potassium replacement during our salt loading protocol. So we'll salt load for 3 days, and on the 3rd day we'll ask our patients to begin a 24-hour urine collection. They then bring that urine collection to our lab at the end of the 3rd day, or the beginning of the 4th day actually. And what we measure are urine creatinine, total volume, potassium, aldosterone, and sodium. And by most measures, the definition of autonomous aldosterone secretion would require a urinary sodium excretion above 200 millimoles per 24-hour period, and a measured aldosterone excretion rate in the urine of above 12 to 14 micrograms per 24-hour period. A typical normal value would be less than 8, so you can see there's a gray zone in defining hyperaldosteronism. I'm just going to, there's a couple of other questions here. Which is the preferred method for renin measurement? Well, that's a tricky question to answer. I think, one, it depends on the confidence of the lab used. So certainly both plasma renin activity measurement and plasma renin concentration are used widely. And the ability for someone to measure plasma renin activity precisely depends on the conditions of the collection. So if there's a high degree of confidence in that the collection is being done correctly, then more often than not, most of the guidelines follow plasma renin activity. Now that might change as more sophisticated renin concentration assays occur and are validated relative to their performance to plasma renin activity. I'm just going to flip through a couple more questions here. So here's an interesting question. Is there any evidence that explains or suggests why African Americans have lower renin levels independent of salt intake? And that's certainly a question that we ask in our research group. I guess it's easy to speculate that it's a combination of genetic pressure and environmental conditions. So it's certainly clear that when we compare African Americans in our research cohorts with our Caucasians, that they universally have lower plasma renin activity. And then when we look at their genetic makeup of either renin polymorphisms, angiotensin II polymorphisms, angiotensinogen polymorphisms, we definitely see a discrepancy in the prevalence of those polymorphic variants. So there's certainly a body of evidence that would suggest that it has to do with genetics or genetic pressure over time that's leading to suppression of renin. Aside from that, there are certainly reports that it has to do with dietary intake, such as dietary intake of potassium, sodium, that might vary between populations. Clearly an active area of research that's not quite settled out yet. So another question I have that was submitted is how do you handle the collection challenges of samples for your assays? Is it an endocrinologist concern or the clinical lab? I'm assuming that is what it's asking, the clinical chemist, clinical pathologist. So I guess it's a combination. For our research purposes, where we needed to have very precise measurements, it actually ended up being an educational endeavor where we would describe the required steps to have an accurate and reproducible renin measurement. I would imagine in most large laboratory setups that there's a standard operating procedure for both the collection, processing, and assay of renin. Certainly, as with most laboratory measurements, it never hurts to get 2 or 3 assessments of renin activity to feel confident with the measurement. Another question is, in resistant hypertension associated with primary hyperaldosteronism, what proportion are normal kalemic? And that's a great question because it's, I think in the past, and it probably contributes to the changing rate in the prevalence of primary hyperaldosteronism, or the appreciation of that rate, is that we classically had defined or investigated primary hyperaldosterone only in patients who had hypokalemia. However, it's probably that up to a quarter of patients, maybe even a third of patients with primary hyperaldosteronism do not have hypokalemia, where they have normal kalemic values or normal serum potassium levels. So again, if there's I think it's important to remember that if somebody's requiring more than 3 medications in spite of normal kalemia, to entertain hyperaldosteronism given its higher prevalence. Sometimes that can be teased out. As I mentioned, the use of diuretics is actually part of the definition for resistant hypertension, and often what we'll see is an exaggerated hypokalemic response to starting a diuretic such as hydrochlorothiazide or a potassium wasting diuretic. So sometimes I find that useful in unmasking primary hyperaldosteronism. Obviously somebody with on large doses of potassium repletion can have a normal kalemic value on evaluation, but it would be up to the clinician to appreciate that normal kalemic value is in the setting of high potassium intake. Yeah, this is another great group. Another great question. I'm not sure I have a solid answer for this, but it says, how long would patients have to be treated with hydralazine until the renin goes back to its baseline concentration? That's an excellent question. So in the evaluation of primary hyperaldosteronism, clearly if that occurs most often in a resistant hypertensive state, there would be several medications on board. Each one of those could interfere with the interpretation of the renin-angiotensin system, renin-angiotensin-aldosterone system. Typically, if it's safer and probably just as sensitive to leave patients on their antihypertensive medications, probably with the exception of the mineralocorticoid receptor antagonists, spironolactone and eplerenone, which would clearly alter the aldorenin ratio. But in most cases, given the high cutoff points for plasma renin, for aldorenin ratios, you can pretty much leave people on their medications. And the off chance that you actually have to, or it's not clear, we typically allow about a month for medications to wash out. Now, if it's an ACE inhibitor, an ARB, or even a mineralocorticoid receptor, we've seen renin activity maintained by the effects of those medications out to 3 months. In fact, most of our research protocols require that ACEs, ARBs are washed out for at least 3 months prior to assessment of renin. That may not pertain to clinical relevance since the suspicion's somewhat different than in a research standpoint. But about a month is what we typically would do in practice. For mineralocorticoid receptor antagonists, we've certainly seen up to 4 or 5 months of persistent activity on the renin-angiotensin system after washout. What is the treatment or care for resistant hypertension? That wasn't quite where I wanted to go with the talk, but I think it's certainly a relevant question. It would be first identifying those contributing causes. So obviously, if there is established primary hyperaldosteronism, there would be either removal of an aldosterone-secreting tumor if encountered or diagnosed, or treatment medically with mineralocorticoid mineralocorticoid receptor antagonists. Now, I would point out that there are several reports of the potency of using mineralocorticoid receptor antagonists in the treatment of resistant hypertension. There's been reports of a large blood pressure lowering effects in that setting, and that might have to do with the ability of aldosterone antagonists to provide a more potent either diuretic effect or tamping down of the renin-angiotensin system in an otherwise very heightened state of renin-angiotensin system activity. So often that'll be the drug that we pick even in the absence primary hyperaldosteronism. Beyond that, we typically turn to clonidine with a beta blocker. which is typically on board. And then I actually prefer minoxidil because I think it's a very potent antihypertensive agent, but must be monitored carefully. A question asks, is it vital to include 24-hour urine studies as a way to screen for hyperaldosteronism, or is ARR enough? So it's a two-part question. And then what additional information is gathered from the urine studies? So the aldorenin ratio is an excellent screening tool, but it's not a very good diagnostic tool for aldosterone excess. It gives a high suspicion, and certainly I would imagine the specificity of that test increases drastically as the ratio rises. But it is really meant to be a sensitive test. So to establish the diagnosis of inappropriate aldosterone secretion, one must first suppress or introduce measures which will suppress normal aldosterone activity. As I mentioned, that can be as simple as loading with oral salt to a high level, or it can be a saline infusion, or it can be one of two less commonly used antagonist procedures. So the point would be to raise sodium levels to a level that we know should suppress aldosterone activity. Typically, that's measured in a 24-hour urine collection, so we can gauge the amount of sodium intake relative to the amount of aldosterone that's encountered in the urine specimen. So that would typically be the diagnostic assay for measuring, confirming the diagnosis of primary hyperaldosteronism. So a question is, how fast would you like a renin test to be? Is that a few minutes? How many renin tests do you order monthly? So I'm not sure if that's referring to the plasma renin activity or the renin concentration assay. Usually a standard plasma renin activity assessment is for 90 minutes, but as I mentioned, the incubation period would be for 90 minutes. But as I mentioned, sometimes, depending on very low concentrations detected, that can be extended out to 18 hours. Costs are variable. Plasma renin activity costs tend to be very high because they're very labor intensive relative to plasma renin concentrations, which can be measured with immunometric assays. So somebody had asked how we might be able to get a copy of the slide. So I think on my last slide here posted, you can certainly just email me. I'm happy to email out a PDF file of the slide set. And then I just want to point out on the last slide, I'll put it up here, there is a link for obtaining CME credit for this activity, which you can click on. There's a question that asks, is there a benefit in classifying non-resistant hypertension as high renin or low renin? Certainly that's my question I have too. Most of my research has to do with determining subsets within hypertension. And the endpoint would be clearly perhaps to provide more targeted and beneficial therapy to the patient through improved compliance, decreased costs, etc. So I would clearly be biased in saying, yes, I think there's a clear benefit for being able to subset hypertensives into high renin or low renin. That's certainly been attempted in the past with variable effectiveness as far as targeting treatment. One might think that a low renin state would be one in which a diuretic would be beneficial, since a low renin state often reflects a volume expanded state. And therefore, use of a diuretic would be, should be important in that state. That's invariably been reported as successful. Versus a high renin state, one might think you would block the angiotensin 2 or block any renin activity very proximally. It just hasn't quite been worked out yet, and I think it probably has to do mostly with the experimental conditions in trying to assess renin activity. They're not consistently reported by investigators. So it's certainly an effort that's been going on for decades to try to accurately classify subsets within the hypertensive population in an effort to improve outcomes. Just flipping through a couple more of these. So, since this was asked a few times, which method of measurement would you favor, me, myself, plasma renin activity or immunoassay, and why? I guess we've been favoring the plasma renin activity just because we're very familiar with it, and since we have most of our research protocols are longitudinal, that it'd be very difficult for us to switch over to a different assay since it would interfere with our kind of longitudinal comparison of our population. So that's probably the most important reason why. And then I think the second might be that for right now, most of the societies that provide guidelines in the workup of resistant hypertension have been favoring plasma renin activity. Again, maybe because there's been more experience with that and it's a little bit more standardized. But I would imagine as there's more interest in measurement of direct renin and total renin, that will change over time, especially since the cost should be much less for measurement of direct renin than plasma renin activity. Just yet to be seen if the accuracy can be matched. So an important question is, how do you interpret the renin-aldosterone ratios in the setting of somebody who's on an ACE inhibitor or an ARB use, especially when patients have absolute indications for these medications, such as conditions of congestive heart failure? So that's a great question. I might have hit this one before, but I would say more often than not, we will continue to assess the aldo-renin ratio without withdrawing these medications. I think where it can be a little bit more difficult is in the 3 months after initiation of these medications. So typically, aldosterone escape occurs beyond 3 months. So in the first 3 months, you can have difficulty interpreting the aldosterone part of the aldo-renin ratio. So usually we would wait, and I can't think of many cases where I've been faced with that dilemma of entertaining a primary hyperaldo diagnosis in somebody who had recently been started on an ARB or an ACE inhibitor. But I would think waiting 3 months would be fine in order to provide a little bit better reliability of the ARR interpretation in those patients. So there's been a couple of questions asking which particular kits are we using. I probably can't, probably shouldn't say that just for conflicts of interest. This I'm not sure of. There's a question that asks, is there any data published for aldo-renin ratios as screening for primary hyperaldosteronism for mass assays instead of activity assays? By mass, I assume that means plasma renin concentration. There's certainly been several head-to-head comparisons of assays that have been reported with very variable degrees of confidence in comparing those. I'd say most of them report that plasma renin concentration is as good as plasma renin activity. I think what's difficult to interpret or translate into clinical practice are the conditions of a research study versus those of clinical practice. So in a research study where you're doing direct comparisons, it's much more easier to define your comparison populations to make sure they're as close as possible. So for instance, somebody who is on oral contraceptive or estrogen hormone replacement, they might be excluded from a research study that's comparing direct renin concentration to plasma renin activity. However, in clinical practice, that wouldn't be that may not be possible. So as with any research study report, you have to be able to interpret the context of that research and how applicable it's going to be to your clinical practice. Certainly there's been a lot more activity in comparing the two assays to report confidence of plasma renin concentration versus plasma renin activity. And as I mentioned at the onset, I think where we might see a lot of excitement is in better defining the lower range of the sensitivity of these assays given the high salt diet that we encounter. It becomes increasingly difficult to measure plasma renin activity when there are high salt conditions. And I think there's more room for poor reporting of false positives, higher aldo-renin ratios in that setting. One would hope that the measurement of direct renin concentration might have an advantage on those lower ranges, since they might be able to have an immunoassay that can be more sensitive at the lower limits of detection relative to plasma renin activity. So I guess I'm hopeful that that can occur to help clean up some of the noise we have in the PRA assay, in particular when measuring or in trying to screen for primary hyperaldosteronism. A question is, in your opinion, what's the true prevalence of primary hyperaldosteronism? And can we speak of occult primary hyperaldosteronism? So we reported on this in our group about, I think it was about 8 years ago, because at that time there had been such a high rate of reported primary hyperaldosteronism, and we ourselves were a little bit taken aback by the reported rates. And then realizing that they were probably mostly from referral hypertension clinics, we looked at our general hypertensive population, which actually excludes resistant hypertension, and I think we reported a rate of about 6% in a general hypertensive population. I think what's difficult to know is the trajectory of the time course of primary hyperaldosteronism. As with anything, somebody must start, even those with primary hyperaldosteronism, must start with a level of hypertension, even a low level of hypertension. They don't wake up one day with a blood pressure of 190 over 120. It's more likely that they progress through the spectrum of hypertension, yet they do so more quickly or more resistantly than essential quote-unquote hypertension. So I think occult primary hyperaldosteronism certainly exists, and as I was mentioning earlier, we just need to develop the tools of detection so that we can identify those folks quicker and not so late in the game when they have 10 years of accumulated damage and our interventions are less effective. So there certainly needs to be a drive, and there has been. There's been certain reports of genetic polymorphic variants that lead to familial primary hyperaldosteronism. So there's hope that that can be interpreted and translated into screening individuals down the road. We're just not there yet. So I think we have about a minute left. Let's see if I can pick one more of these. What is the clinical definition of resistant hypertension? I think I hit that. The clinical definition would be an uncontrolled blood pressure greater than 140/90 that is despite use of 3 antihypertensive medications, one of which includes a diuretic, and compliance with those medications. So there was a study recently conducted which was just trying to enroll patients specifically with resistant hypertension. And Given the prevalence reported, one would have thought that would have been an easy task. However, when placing the caveat of eligibility that one must assure compliance with medications before defining resistant hypertension, the actual ability to recruit and identify resistant hypertension dropped down to 1%. So it became increasingly difficult. So clearly, compliance with medication is a big part of diagnosing appropriately resistant hypertension, and that should be an important part of evaluating it. So I think we're all set, unless I hear otherwise from the team. Dawn, you just let me know if there's anything else. Again, I'll refer to the last slide, which provides a link for CE credit, and then I'm going to flip back one slide and push that to the audience, which again lists my contact information. Feel free to contact me at my email, and I'd be happy to try to answer your questions, and certainly provide a copy of the slide set as a PDF to you. Dawn, I'll let you sign out when you think we're done. Thanks again.